All right, welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for community health at Atlantic Health System. Today's webinar, Headaches and Migraines, is presented by Dr. Seth Stoller. Before we begin, I do have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or chat for comments. We will try to get through all of the questions at the end of this presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke free. There are multiple dates and times available, with groups available both in person or virtually. For more information about these groups and other resources, or for any additional dates and times, please call 1-844 472 8499. I am now going to turn it over to Dr. Stoller.
Okay, good morning, everyone. I'm Seth Stoller. I just want to make sure, is this on? Okay, let's see. Are we on? Do we have the slides coming up now? I just want to make sure. I'm going to switch it to slideshow. Okay, great. Ashley, I just want to double check the slides are up.
Yes.
Great, perfect. Well, good morning, everyone. Welcome and happy Friday, June 9th. I'm going to be speaking today about headaches and particularly about migraines. So for those of you who don't know me, I am Seth Stoller. I'm the section chief of neurology at Overlook, and I'm one of the neurologists through Atlantic Health and specifically Atlantic Medical Group. My main office is in Summit. I also have an office in Rockaway, New Jersey. I'm a lifelong native of New Jersey. I grew up in Morris County, and I still live in New Jersey. I have headaches. I get them quite frequently. I get migraines occasionally. And so this is near and dear to my heart. When I started practicing neurology, there was not a lot of science on headache. It's really evolved over the last 20 years, particularly over the last 10 years. So the treatments that were out in the 60s, 70s, 80s, early 90s are really transformative to where we are now, into some great new technologies and medications. So we're going to start the lecture just going through the headache subtypes. So if I went through every type of headache with you today, we'd have a lot to cover. In fact, I'd have to talk about 230 different types of headaches. We divide that into primary and secondary. So the ones you know well, or heard of, include tension, which I'm going to talk about, migraine, cluster, sexual headaches, exertional headaches. I'm not going to cover those in this lecture due to time. There's also secondary headaches, and these are headaches that are caused by another medical issue. So the one I deal with very regularly are trauma-related headaches or post-traumatic headaches. I see patients who have had a concussion, which is a mild traumatic brain injury, all the way to a major traumatic brain injury. And I see quite a few patients with that at Morristown and Kessler. Vascular headaches or headaches which are due to aneurysms or brain hemorrhages. Cervical headaches are due to neck injuries. And then people can get headaches from just about any other medical condition. And then the last type of classification of headaches are facial pain or cranial neuralgias. So anything of the face or of the what we call the facial nerves. Okay, so this is a slide where we cover the prevalence of headaches. So this is a study done in the late 90s, and it really shows in the population what is the prevalence, how many people get headaches. And as you can see here, where I'm highlighting, migraines occur in 18% of women nationally and 6% of men nationally. And the average there's about 12% of the population. Tension headaches are 41 and 40, but the reality is that's for episodic tension headache, meaning at least 5 per year. There's many people that have tension headaches per year. More than that, just for not reporting. It's estimated up to 80% of the population gets it. And then unfortunately, frequent headaches can occur in the population, meaning over 15 attacks per month, half the month, in 5% of females and 2.3% of males. Okay. All right. So another survey, and this is what I was alluding to before, 80% of the population has ever had a headache and 75% has episodic headaches. And down here, what meets the criteria for migraine headaches by a neurologist definition is 12% of the population. Interestingly enough, about 5% of the population gets what we call chronic daily headache or a headache every day. Okay. So this is a picture of one of my patients. And he's come to me several times in the past couple of years, and he always has the same story. He comes in and he says, "Doctor, I have this headache. It is very bothersome. It is spread throughout my entire head, and it feels like a vice, and nothing makes it go away. It just kills me." So unfortunately, my patient Arnold S., and I won't give away his name, but he has tension headaches, and these are mild to moderate headaches. They occur on both sides of the scalp, and it feels like tightness or pressure. It's typically dull, and it lasts hours to days. So these type of headaches, we don't have what we call neurologic symptoms. So we don't have weakness or numbness. We don't have nausea or vomiting. And unfortunately, people with these type of headaches don't seek help until it's too late. So they don't see us until the frequency of the headache is over 10 times per month on average, and the disability is high, so they're missing days of work or time with their family. And we really wish we could see some patients earlier to help them. These headaches last 30 minutes to 7 days. They're bilateral, so that means they're on both sides of the head. They're pressure tightening. They're not pulsating. They don't feel like lightning. They're mild or moderate in intensity. They're not the worst headache of anyone's life. And they're not typically aggravated by physical activity like walking or going upstairs. We don't see nausea or vomiting with this, as opposed to migraines, which we'll talk about next. And you can have 1 or 2 episodes, but not more than that, of light sensitivity or photophobia, meaning a fear of lights, or sound sensitivity or phonophobia. And we don't have another explanation for this, meaning you don't have sinus issues, you don't have allergy issues. These are just headaches, and there's no underlying medical issue. This is most common at age 40 to 49 in both sexes. The prevalence is about 46%. The chronic tension type headaches, meaning these are going on for over a year and they're very frequent, is only 3% of the population. This is more common in males, 5, to females, 4 on a female to male ratio. So whereas migraine headache is more common in female, tension headache is slightly more common in males, but not much. The prevalence of this increases with educational level. Why? People with higher educational levels have higher levels of stress, possibly. Is it they're reading more? Possibly. There's a million different reasons to explain that statement, but it is something that was found in research. There's no definitive correlation, but it does increase with educational level. And unfortunately, this can occur in children. Why? Kids get stress. Kids can have neck injuries. Kids can have bad posture. All these things contribute towards tension headaches because they're muscular. This can be overlapping with migraine headaches because basically these features can disappear in a migraine, and in a tension headache, they can continue to go on. People with neck injuries will often have a muscle tenderness, which is very similar to tension type headaches, and that can involve the neck. And then there's a type of headache that's very frustrating for many patients and doctors alike, called medication overuse headaches. So we see this in patients who are taking opioids or combination analgesics, and a combination analgesics means Tylenol or Motrin and caffeine. So an example of that would be Excedrin, which is over the counter, or Furacet, which is prescription. And this can go on for over 10 days per month. And believe it or not, this type of headache, by taking medication too frequently, you cause a headache. So these things kind of overlap and can present like tension headache. All right. So the next type of headache is migraine headache. And as I showed on a slide before, in America, we have 12% prevalence in the population. In females, it can range from 18 to 25%, depending on the study, but it hovers at about 6% men. In Denmark, it's slightly higher in both men and women. An interesting study here in Saudi Arabia, only 2.6% of the population has migraine. In Hong Kong, only 1.5%. So we don't understand quite, oh, going the wrong way. We don't understand quite why it's so low in those countries. Is it climate? Is it cultural? Do the patients just not report migraine headache? But it was an interesting finding. When does this occur? It occurs in younger patients. It occurs in teenagers, 20-year-olds, and usually the latest onset of the first migraine occurs in 35 to 45-year-old people. So it's usually under 45. When I start seeing patients who are having their first lifetime migraine after 45, I start questioning, is there something else going on? The incidence is increasing. In 1992, it was estimated to have 23 million Americans with it. Recent studies show it's much higher, more in the 30 to 40 million patient range. Okay, so I want to just highlight one thing on this slide. So 80% of patients who have migraines have lost some work due to their migraines or secondary to their migraines. Up to 33% require bed rest, which obviously causes them to miss work. For males, it was 3.8 days per year. For females, 5.6 days per year. So when we add this up, there's 112 million work days lost per year in this study. Back in 1992, there was an impact of $13 billion on the economy caused by migraine loss and $2.5 billion in direct loss. So that's probably with inflation double that. But I'm not an economist, but you can see there's quite a bit of time and work revenue lost due to migraines. To me, a more significant finding for those of us who have families, 17% of family activities are canceled as a result of migraines. So that's problematic if you're missing 1 out of 5 activities with your family. Why don't we talk about migraine more? I don't know. When I was in medical school, I had one lecture of 30 minutes in 4 years. So this is why I got involved in migraine education. This slide really will show you that migraines occur in this study in 1993 in 14.8% of the medical field. So this is in presentations to doctors, not estimated in the population. Just this is from what people are coming to the doctor with. 7% asthma, 6% diabetes. So migraine actually accounts at 14.8%, much more than asthma and diabetes combined, and osteoarthritis, rheumatoid arthritis. And yet we do not educate the public on this, and certainly we don't educate our doctors enough, but we're making strides on that front. As a neurologist, if you study migraine and you know migraine, you're going to be able to take care of, believe it or not, 12% of the patients that walk into your office without any issue. So this is the most common neurologic disease. 12% of the neurology patients are migraineurs. 6.7% have Alzheimer's disease, 1% have stroke, almost 1% have Parkinson's disease plus Huntington's disease. Epilepsy or seizure disorder is 0.71%, and multiple sclerosis or MS is 0.09%. But again, migraine is the most common neurologic disease that we see. So who gets migraines? And when we were talking about higher levels of education, these are always slides that I enjoy presenting. So going back in time, Julius Caesar had migraines, and it's thought that some of his visions that he had were actually migraine aura, which we'll talk about soon. Joan of Arc used to have visions. She would see literally flames and lights, and it's thought that some of that were migraine aura. Cervantes, who wrote Don Quixote, had migraines. Pascal, who created mathematics, which probably we all struggled with in high school, but we made it through, had migraines and gave us headaches. Thomas Jefferson, who wrote the Declaration of Independence and one of our founding fathers, had migraines. Napoleon had migraines. Edgar Allan Poe had migraine. Karl Marx, who came up with a failed experiment called socialism, had migraines. Charles Darwin, who's one of the great evolutionary thinkers of history of the world, had migraines. Chopin, who was a composer, Robert E. Lee, who was the Confederate Southern general, and from representing the northern side in the Union, Ulysses S. Grant. Both generals had migraines. George Eliot, who really was Marianne Evans, had migraines. Tolstoy, who wrote War and Peace, which gave us a headache at times, going through 800 plus pages. Lewis Carroll had migraines, and there's an article in Lancet in 1999 by Dr. Chakravarti, who I used to know, and he speculated that Lewis Carroll had migraines due to the fact that he actually talked about this in his writing. So when he did Alice in Wonderland and wrote that, he was basically saying that some of the visual distortions that Lewis Carroll had, so Alice got too big, Alice got too small, this checkerboard phenomenon, these were phenomenons that were inspired by his own migraine headaches that he had journaled about. And they're also experiences that other people who have migraines see in an aura. Sometimes people see a checkerboard-like pattern. Sometimes people see their vision get distorted, so things get too big or too little. So it's fascinating, that theory that Alice in Wonderland was inspired by a migraine headache. Albert Nobel, the namesake of the Peace Prize, Tchaikovsky, another composer. Nietzsche, great philosopher. Alexander Graham Bell, who his company was headquartered around here for many years. Vincent van Gogh, Starry Night, the art piece, was inspired by a migraine. I'm going to show you that later. Woodrow Wilson, a native of New Jersey and Princeton, a president. Sigmund Freud, who was the father of psychiatry, but actually a neurologist. George Bernard Shaw, the playwright. And then I call these modern migraineurs. Some of them are a little less than modern, but Elvis Presley had migraines. Stephen King has migraines. Whoopi Goldberg, Loretta Lynn, coal miner's daughter. Joe Girardi, the former Yankee player and coach. Fred Couples, a golfer. Scottie Pippen, who played with the Bulls. Terrell Davis, who played with the Denver Broncos. Interesting story on that. In the 1998 Super Bowl, Terrell Davis had a migraine in the second quarter. And if you watch the highlight of the film, Mike Shanahan, who's his coach, acknowledges there's something wrong. Terrell Davis comes to the sideline and says, "Coach, I can't see out of my right eye." And he goes, "All right, go back in there and block," which we would never do these days. But he sent him back in the game despite the fact that he couldn't see straight. At halftime, Terrell Davis came into the locker room and was given a migraine medication we use nowadays and was better. He went back in the game. His vision improved, his headache improved, and he wound up rushing for about 200 yards and was the Super Bowl MVP. Interesting side note. So migraine can overlap with tension headache. Here's a picture of why oftentimes when we get tension headache or migraine headache, neck pain overlaps. And this is where we see it. Stress is a common migraine trigger, and it's the main trigger of tension headaches. And oftentimes migraine is on both sides of the head. Sinus headaches are often mistaken for migraine headaches. There's often pain in the sinuses in the front. Migraine is often triggered by weather changes, just like sinus headaches. And sometimes in migraines, we can have tearing and nasal congestion, just like we do in a sinus headache. In rare cases, sinus medication helps migraines, but I don't really recommend that. So this is Marilyn Monroe, for those of you who don't know, but this is a good depiction of what a migraineur will experience. So migraine headaches have to have two of the following criteria. So unilateral means only on one side of the head. Throbbing. Moderate to severe means it's intense. Aggravated by movement. And then it has to have one of the following: nausea, light sensitivity, or sound sensitivity. Again, photophobia and phonophobia, meaning photo light sensitivity and phono sound sensitivity. So this is without aura. You have to have at least 5 lifetime attacks. If you only have 4, you don't meet the criteria. Once you get your 5th, you're there. I kind of feel that's a lost criteria, and I think if you have 2 or 3, you still have migraines. Nausea will happen, sometimes vomiting. And again, aggravation by routine physical activity. So many migraineurs are bedbound. They can't walk outside. They have trouble going up and down steps while the event's happening. It's that severe. So this is what kind of one of my old prior research interests was, migraine with aura. So what is an aura? An aura is a warning. So we have migraine auras, and it's basically an episode where we have transient neurologic symptoms for, anywhere from 5 to 60 minutes, and it has to last less than 60 minutes. So we can have visual auras, and these are visual distortions. One of the common types is called a scintillating scotoma. So we have this little jagged edge line, and then it expands and it can look like a blind spot, but it's flashing light. We can have what's called a fortification spectra, which is literally like stacked Lincoln logs. And then we can have photopsia, where we lose a visual field. So here's a nice picture drawn by a patient who probably should not be driving, but drew this. So here they are driving and they lost their entire right visual field. So I always tell patients, if you feel like you're having an aura and your vision is not 100%, pull over. Do not drive any further. Do not have a car accident with reverse on your right side. Sometimes patients have sensory auras, so they can have numbness in their arm or leg, paresthesias or tingling, pins and needles in their arms and legs. This is sometimes on both sides, but usually on one side of the body. Sometimes people get transient weakness, not to the point where they can't move anything, but just weaker. And then sometimes they have what's called aphasia, which is an inability to speak. Again, migraine with aura, the aura cannot last more than 60 minutes. If the aura symptom goes 61 minutes, I instruct all my patients to get in the car or have someone drive them to the hospital or call EMS. If it goes over 61 minutes, by definition, it could be a stroke or a transient ischemic attack or something else, but that's not a migraine aura. These gradually develop from 4 minutes to up to that 1 hour, and they're reversible. So those visual things I showed you go away in under 60 minutes. Now, after the aura comes the migraine headache. And this is a slide showing the phases. So oftentimes people have a prodrome, whether they have an aura or not, they have a prodrome. They just don't feel right. They have this malaise, this icky feeling, even before the headache comes. 1 in 5 patients who has migraines, only 1 in 5, 20% of the population of migraine patients has an aura. And that's what we were just talking about. After that comes the headache. And the headache starts, and then after that and during the headache, we get associated features. So that includes nausea, light, and sound sensitivity. After that, we have what's called a postrome. And again, that's feeling malaise, fatigue, tired, icky. This whole process can last anywhere from 2 hours to 72 hours, rarely more than that. Usually when we get to this point here, it's at 24 to 48 hours, but it can be less than that. Sometimes I'll have people have a 96-hour migraine, but that's usually partly the postrome, that after effect. So what are the common triggers? Well, stress is a trigger. It's almost 80% of the population of migraineurs have triggers from stress. So that's often emotional. Hormones are a trigger. Usually it's a fluctuation in estrogen. So I see a lot of women who have menstrual migraines. So they have a migraine during their menstrual cycle, whether it's during menses and their actual period, or they have it during their premenstrual cycle. Not eating or hypoglycemia is very much a trigger. So I have a lot of patients who are doing fad dieting, intermittent fasting, and they start getting an uptick in migraines. And we start talking about maybe coming up with other dietary mechanisms to help. Weather. So it's not so much a specific weather, but it's a change in weather, like barometric pressure. So I have a major trigger of migraines when there's a big storm. So I don't get this in a rainstorm. I don't get this in a mild snowstorm. I get this in a hurricane. I get this in a blizzard. I had a terrible time with Superstorm Sandy. Barometric changes in a rapid nature from very high or low or vice versa is very common. Sleep disturbance. So too much sleep or too little sleep is common. Perfumes or odors. Very rarely do I see migraineurs in my office who come in wearing a ton of cologne or perfume. Um, it usually bothers them even when they don't have migraines. Neck pain or a neck injury can trigger migraines. Lights, specifically fluorescent lights. So I see a lot of athletes, New York Jets, New Jersey Devils, and one of the big triggers that they have that we don't have is from stadium lights or arena lights. Why? The intensity of the light can be that severe. But I do see a lot of non-athletes who get triggers from just fluorescent lights in their office. So alcohol of any type can trigger a migraine, but the most common subtype of alcohol is red wine, especially cheap red wine. Smoke is a trigger, sleeping late is a trigger, heat can be a trigger, certain foods are triggers. So foods with high sodium, like hot dogs, MSG, chocolate is a major trigger, cheese is a major trigger. Now, interestingly enough, the older the cheese, the more it's aged, the more likely you're to get a migraine. And more interestingly enough, cottage cheese does not typically cause migraines. Interesting fact. Sexual activity can cause a migraine. Again, this is a picture of an aura of what we call a scintillating scotoma. And I just want to highlight how it can evolve. So you have the onset, you'll get this squiggly line. And then after 10 minutes, you'll get the line with some fill on the border. And then after 20 minutes, you get the squiggly line, the fill, and then an actual blind spot. And then by 40 minutes, that blind spot expands. So it's just kind of a time course on how this can evolve. I find that fascinating. So 20% of migraineurs experience, and there is an organic cause for this. This happens in the brain in what we call spreading depression. And I'm not going to go too much into neuroscience, but this is a fun fact. So what happens is you have blood flow in the brain, and this is the back part of the brain called the occipital lobe. This is kind of the movie projector screen of all of your vision from your eyes. It maps out back here. So when we have a migraine, we get this surge of blood flow, okay? When you have an aura, you get a lack of blood flow. Why? It's almost like a wave. And when the wave leaves the occipital lobe, you get what's called hypoperfusion or less blood flow, not a lack of blood flow, but less blood flow. And as a result of that, oftentimes you'll get this blind spot because the blood flow is not there. The picture's not getting portrayed to the movie screen. As the flow of the blood goes and surges forward, you get what's called hyperperfusion or faster blood flow. And that's really where our headache is. So it's an interesting thing to think about. It's kind of like a wave. This is one of the more eloquent studies we've seen in neuroscience. So I love art and I take care of migraineurs. So this is a painting called God and Man by Blake. And this is a painting that many of you have seen over the course of your life at garage sales, Bed Bath & Beyond, and many paintings and posters. This is Starry Night by Van Gogh. Now look at this here, and look at this here, and look at this here. It's all pretty similar to what we see here. It's probably a migraine aura inspiring this. So biographers of Van Gogh have speculated that some of his migraine auras were accounted for in this. Other biographers have speculated that he had such intense pain on his ear, which may have been due to a migraine, that he cut it off. So just some fun facts. This is Salvador Dali, and this is something called photopsia, where your vision splits. Again, Dali had migraines, so speculation is that this migraine aura inspired this painting. People who have migraines have other medical conditions in a higher frequency. So many people who have migraines have anxiety more than depression, but can have that coexist. Autoimmune issues in the colon, so ulcerative colitis or Crohn's disease, inflammatory bowel syndrome, irritable bowel syndrome. For some reason, people with migraines have higher levels of allergy and asthma. We find that many people with migraines in a subset have PFOs or patent foramen ovale, which is a small hole in the heart. Mitral valve prolapse is another leakage of the heart. In neurology, we see more people with migraines have epilepsy or cervical dystonia, which is a spasm of the neck, involuntary movement. So it's just something we've noted. Something else that I want to bring up in case any of you out there are younger and have migraine aura and smoke and are on an oral contraceptive. When you smoke, your odds ratio of having a stroke is twofold for the general population. When you smoke and you're on an oral contraceptive, it's sixfold to the general population. Unfortunately, if you have migraine with aura, you have a higher level likelihood of having a stroke than general population. That's only with aura, not without aura. So you have a 3 to 6-fold chance. Now, if you have migraine with aura and your primary care doctor or obstetrician puts you on a birth control pill, you can go up to 5 to 17-fold increase from the general population. Now, if you have migraine with aura and you're on an oral contraceptive and you smoke, you have a 34-fold higher risk than the general population have a stroke. So I just want to educate anyone out there who's a smoker on an oral contraceptive and actually has migraine with aura, either quit smoking, ideally, come off the oral contraceptive as well, and look at alternatives. So the highest level of risk is in 50 micrograms of estrogen or estradiol. If people have migraine without aura, there's no what we call contraindication, meaning you can do it and you can take it and not worry about the risk. But when you take high dose estrogen, it's the highest risk. So we always have that risk benefit discussion with patients when they have this, that yes, this will help your hormonal levels and cycle. Yes, this may help your migraine, but unfortunately you're at a higher risk for stroke. So we try to control that. All right. So how do we treat migraine? We have two types of classifications of medications. The first is called acute or abortive, and the second is called prophylactic. The acute we take only as needed. These include non-steroidal anti-inflammatory drugs like Motrin, Advil, combination analgesics, Excedrin, which is Tylenol and caffeine and aspirin. Tylenol is a treatment. Opioids I don't like to use. Neuroleptics, such as Seroquel, I don't like to use, but they have been used. Antiemetics, which are anti-nausea medications, I do use. Corticosteroids, I don't like to use. What I like to use are two medications. One's called triptan, so that includes sumatriptan or Imitrex, rizatriptan or Maxalt, elatriptan or Relpax, zolmitriptan or Zomig, and there's three others that I won't name. CGRP antagonists are a new classification of drugs that came out about 4 years ago. So that includes Ubrelvy, which you may have seen with the Serena Williams commercial, or Nurtec, which you may have seen with the one of the Kardashians commercials. And those are the spokespeople for it. They're great drugs. People ask me all the time, which one's better? And the answer is neither. They're very equal. It's what your insurance covers or doesn't cover that guides my recommendation on that. These medications are fascinating, both the triptans and the CGRP antagonists. This is a picture of the bottom part of your brain called the brainstem. And there's an area in here called the trigeminal nucleus. And what that does is it maps out to your face in 3 branches. So that's where facial pain occurs. So this area here is the relay for all of these nerve endings that come from your face and scalp. And down here is like Grand Central Station. Everything interacts. And it feeds back. So the input comes from your face and scalp that there's pain. It feeds back up through your face and scalp through what's called the trigeminal nerve, and it interacts with the blood vessels there. So these blood vessels run under what's called the dura mater, which runs between the skull and the brain. So all these messages kind of get interwoven there. So it's a fascinating thing and very eloquent how that works. Because it really works directly on the Grand Central Station of where all the messaging is coming. So when patients have more than 5 migraines per month, I like to do preventative therapy, meaning start them on something daily or monthly to try to reduce the duration, frequency, and severity of their migraines. This oftentimes improves their responsiveness to acute treatments, and it improves their function and reduces disability. It prevents the disease progression. And ultimately, it reduces costs. So patients don't miss work. Businesses don't miss their employee. Families don't miss time. So there's a couple classes of this. There's what we call anticonvulsants, which include divalproex or Depakote. There's topiramate or Topamax. Depakote can cause weight gain. Topamax can cause weight loss. Topamax, unfortunately, also can cause word finding issues. So we have to be careful who we use and what we use. Gabapentin or pregabalin. There's a class of antidepressants we use, tricyclics, such as amitriptyline, selective serotonin reuptake inhibitors, such as fluoxetine or Prozac, selective norepinephrine serotonin receptor, and it's a long word, Effexor or Cymbalta examples. Beta blockers we use for blood pressure control. Examples are propranolol and timolol. Calcium channel blockers like verapamil. A new class of drugs called CGRP antagonists. And just like Ubrelvy and Nurtec are used as abortive agents quickly, we have longer acting agents that we use. There's an injectable class. So that includes Ajovy, Aimovig, or Emgality. We give an injection under your skin subcutaneously once every 28 days, and it works on preventing the migraines from happening, or at least reducing the frequency, severity, and disability. There's another new medication called Qulipta that came out 2 years ago, which is an oral version of that. You have to take every day, but it's not an injectable. And there's another one that's come out called Vyepti, which is given intravenously once every 3 months. So really great technology. Botox or botulinum toxin A, or Dysport is another brand, are given every 3 months. And I'll show you a picture of that where it's given. Riboflavin, I love vitamin B2, 400 milligrams a day. It's just as effective as many drugs to prevent migraines. It's homeopathic. Magnesium, feverfew is okay. And then some other things. So I asterisk the FDA approved, so it's divalproic acid, Topamax, beta blockers. I didn't put, but CGRP antagonists are FDA approved, as are calcium channel blockers. All right. So Topamax and Depakote I alluded to. This is where we do the Botox injections. I personally don't do it, but I have colleagues that do. So they inject in the front, right over your eyes, in the forehead, on the side of your head, as well as in the back of your neck. There are newer treatments for migraines that have come out. They have not been necessarily any better or worse. We had magnetic stimulation, something called Cephaly, that's a portable device. It literally gives magnets. So that can help. We have new forms of sumatriptan, which is what I call the triptan class. There's Sumavil, which is a kind of a powder, as well as Optinose, which is a breathable nasal spray. So there's different delivery mechanisms on how to get the drug. All right, so that's migraines. I want to just close out with the headache that I see a lot, and I subspecialize in, is traumatic brain injury and post-traumatic headaches. So this is the most common symptom after a traumatic brain injury. And traumatic brain injuries can range from mild, which is a concussion, to major, which is a skull fracture and a bleed. There's at least 2.5 million traumatic brain injuries in the US per year. 75% of these, thank God, are mild. But out of these headaches, almost 91% of people who have a concussion get a headache at 1 year after. So while the concussion resolves, they have headaches afterwards. Moderate to severe traumatic brain injuries, 71% of them have headaches 1 year after. It's interesting because you'd expect the people who had more severe injury to have less headaches than the people who had less severe injury who have more headaches. So it's just an interesting thing. When do we worry? When do you go to the hospital? What is a red flag headache? So anyone, I tell them it's the worst headache of my life and I can't move and I can't function. I've never had a headache like this before. That's something I'm concerned about. What's called a thunderclap headache, where it literally feels like you were struck with lightning or thunder. That one, usually I recommend people go to the hospital for. If you're starting to get headaches over age 40, you don't have to go to the hospital, but do see someone. If your headaches are progressive or worsening over time, see someone. If you have a headache that won't go away after physical exertion, sexual activity, coughing, or what we call a Valsalva maneuver, which is kind of like when your stomach or your abdomen contracts, such as in coughing or a bowel movement, and that headache doesn't go away, I recommend we go to the hospital for that. If you have a headache with nuchal rigidity or neck stiffness, and that's not neck stiffness where you can move your head around, that's neck stiffness where it's like a lead pipe, and that's accompanied by fevers or rash, we worry about meningitis. If you have a severe headache after a major traumatic brain injury, such as falling on ice, falling on concrete, getting hit by a heavy object, those things I usually tell people. If the headache's severe and you have associated symptoms like nausea, dizziness, weakness, confusion, go right to the hospital. If you have headaches and you have a family history of aneurysm or what's called an arteriovenous malformation, we need to get that looked at. Doesn't mean necessarily go to the hospital, but see a doctor. A history of AIDS, cancer, uncontrolled blood pressure, or hypertension, you need to see a doctor. Now, if you have focal neurologic signs, meaning signs of neurologic disease that are acute and are not resolving, so visual change or visual loss that's going on more than an hour, weakness on one side of the body, dysarthria or slurring of speech, aphasia or lacking words of speech, or the inability to speak, ataxia or imbalance, gait instability or difficulty walking, or God forbid, loss of consciousness, go right to the hospital. In the office, and this is more for any medical people out there, there's something called papilledema, which we'll see on exam in the back of your eyes, and that is swelling. We worry about that. If you have a headache and your family notes you have personality changes, aside from mild irritability, like major personality changes, that's concerning. And God forbid you have a seizure with a headache, go right to the hospital. Okay. Well, thank you so much, everyone, for participating with questions, and I hope I've answered everyone's. And I hope y'all have learned something today. If you do have migraine or tension headaches and you have not seen a doctor, please see one of our doctors here at Atlantic Medical Group, whether it's your primary care doctor or one of us as neurologists, and we're more than happy to help you. Have a great day.
Awesome. Thank you for joining us. We kindly ask that you take a few minutes after today's webinar to complete the program's survey. The link to the survey has also been added to the chat for your convenience. A special thank you to Dr. Stoller for dedicating your time and expertise today. If you have any additional questions or comments, you can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. That concludes today's webinar, and I hope everybody has a great day and a great weekend.
Thank you so much.
Thank you.